this will be very informal. So what I put together is a few cases to talk through some of the issues that you'll see in your clinical practice, and hopefully learn something along the way. I did look at the materials that were sent and saw a lot of them were, you know, where you would have to look through videos, which would take a very long time. So I don't expect anyone to come in with the answers. And let's see. And another thing to know is there really are no answers. So all of these cases are from the clinic that I've seen them. They're all completely true, and I didn't change anything except one little thing. I was going to hold back a piece of information on one person, but just like clinical care, there's no right answer or wrong answer. So if possible, with this number of attendees, I was hoping to see if we could still make it interactive, even though I can't see you. So hopefully this will work, and it's up to you guys to chime in as well. So we'll start with, I'm a mother. The things that were changed obviously were the names, but otherwise the stories are accurate. So she's a 30-year-old woman who presented to our clinic in March of 2010. At that time when she presented, unfortunately all too common, is that she was 7 weeks, estimated gestational age at that time. She had a history of seizures since the age of 8 years old. Her seizures were described as a feeling of depersonalization. She felt like she wanted to scream, but she couldn't vocalize. And then at times they would progress to her eyes rolling upward, staring, stiffening, speech arrest under 1 minute, and afterwards feel very tired and have a headache. And these were by her description, so I didn't have a witness, not the best description. And again, she hadn't had any since her teen years, so was not able to get more recent history. Then she began what was more clearly progression to bilateral convulsive seizures at the age of 16 years old, with an aura of thinking, feeling like blank initially, and then would go on to progress to convulsions. This only occurred with medication tapers, however, or non-compliance, as is commonly during the teen years and early adult years, or sleep deprivation. And the most recent one had been 2 years ago, or a year and a half prior to that. In the past, she'd been on carbamazepine, phenytoin, valproate, and at presentation, or when we got called about her, she was on valproate monotherapy. She had no epilepsy risk factors, except actually she had a sister who had epilepsy, but no other risk factors. And she had a history of sulfur reaction as a baby, as a drug allergy. She was working as a flight attendant, and she had seen a fertility specialist, which at that time, the appointment actually led to the diagnosis that she was pregnant at 4 weeks gestational age, and then we got called later. So anyone want to chime in what's sort of concerning about this picture of this presentation, and what could have been done differently at this point? So if you can, someone unmute themselves, and I think actually, you know, we won't be able to identify maybe who people are, but just to chime in, or you can type it into the chat box.
Hi.
Yes.
Obviously, it's concerning that she's on Depakote, considering that it's associated with neural tube defects. So want to try to see if there's any alternatives to consider. That's the first thing that caught my eye.
Yes, exactly. Yeah, thank you. Yeah, and you know, it's also interesting. She was seeing a fertility specialist to get pregnant. So, you know, the fact that this is unfortunately too common, that these things are not considered until much later, when they really need to be part of the conversation when we care for females with epilepsy once they reach childbearing age, whether that's, you know, 13 years old or 43 years old nowadays. Exactly. So that's the concern. And, you know, thinking about what you would do as far as her presenting at that point, if she presented at 7 weeks to you, would you make any changes in her medication? Anyone want to weigh in? So one comment is the concern about neural tube defects, but neural tube already have closed, so we may have missed the window. You're right that it's very early after conception with neural tube development. It's over a range though, but around, you know, 6 to 10 weeks. Someone says they would continue the medication at this point and start folic acid. So I agree, folic acid getting in there at this point as early as possible is important. I'll show you some other information why. Anyone in favor of stopping the Depakote or changing our medicine? So one person said would stop it and switch to something like lamotrigine or Keppra. A good question. What dose of Depakote was she on? Actually, I don't know. This was a while ago. I don't remember what she was on, and I wasn't called at this point. And you'll see that on the next slide. But it brings up a point that there is a dose relationship to Depakote and the risk for major congenital malformations, and I'll show some of that data later. Many of us still feel like, you know, any low dose is still problematic, but definitely the risk is lower with lower doses. So what happened, the neurologist she saw, or going back still to the history, she reported to me that an EEG 2 years ago was abnormal with probable right temporal lobe abnormalities, but she didn't really remember. Last MRI scan was many years ago. She thinks it was normal, and an EEG that day was normal. So folic acid was begun at 1 milligram per day, along with the Flintstone multivitamin. And this was from the outside neurologist. They did decide to stop valproic acid, and they stopped it suddenly with the idea, I think, going back to what was commented on, that if you're going to stop it, if you're going to make a difference in decreasing the malformation risk, especially neural tube defects, then you don't have the luxury of weaning it slowly. So she then had her first generalized tonic-clonic seizure, or bilateral tonic-clonic seizure, about 10 days later. And that was the first one then in a year and a half and two years. So now that it was stopped, this was again by outside neurologists. So they decided to begin lamotrigine. And they began it as 25 milligrams twice a day, the day following the seizure. So would everyone be in agreement with that, or any concerns about that strategy? Slow titration. I kind of like this chat thing, by the way. Thank you guys for doing this. It's kind of fun. I love this. This is fun. Okay, so slow titration is something to consider and of concern if it starts too quickly. But then I can't see names. If it's okay, I'll say first names if it's okay. All of you can probably see them. So Kelly says, need to start something you can start at a therapeutic dose. And too low of a dose to predict, says Diva, if I'm saying that right. So that's exactly right. You know, the lamotrigine is one of the medications of choice in pregnancy is true, but not during pregnancy. You just can't start it during pregnancy because of the need to titrate it slowly. And then also I'll get into the really massive increase in clearance in lamotrigine during pregnancy, so making it even more difficult. So 5 days later, she developed, sure enough, a rash, fever, and joint pain. So she probably had, you know, it's hard to know, 10 days if she really had valproate in her system. But since we don't completely know all those mechanisms of interaction between valproate and lamotrigine and rash, you know, it still probably was a factor. So she was hospitalized for possible Stevens-Johnson syndrome. So now this is actually when I was called at that point, or my colleague, Dr. Zhang Li, was called, who then called me. So then you're called now for urgent consultation. So what would you do at this point? So anyone want to weigh in via chat or microphone? So levetiracetam, I'm going to try to use the generic names. Switch to levetiracetam. So definitely, so Kelly, Robert, and Rahul are all on the same path as I was as well. That's so, yes. Started levetiracetam. It was a few days later. If I was in the hospital, we would have given her IV, but it was a few days later. Started it orally, and then continued with therapeutic drug monitoring. She did well with the rest of the pregnancy, except she went out of town with her fiance and forgot her medication. So she missed several doses and had, unfortunately, a convulsive seizure again. And just at the end of the third trimester, she was on a dose of 1,500 milligrams twice a day. And then kind of going into now, as you're going into planning for labor and delivery, breastfeeding, newborn safety issues, postpartum adjustments. It's sort of, that's a very open-ended question. So starting to think about the different things, we like to see our patients back around 34 to 36 weeks gestational age and start talking about all of these different strategies going through labor and delivery and into early postpartum care. So I'll just kind of go through it. She delivered a healthy baby boy, 6 pounds, 6 ounces via vaginal delivery. After induction APGARs of 8 and 8, she decided to exclusively breastfeed. But however, her newborn was very, very fussy, limiting sleep, and she was up every 2 hours for feeding. And then she had another bilateral convulsive seizures at 5 weeks postpartum. So at that stage, we went back to the drawing board of the things we recommend. I'll come back to the question, thanks, that we recommend going into labor and delivery, and the things because of seizure risk. So even if someone's has had well-controlled seizures, even more so than her, I always think of the time of labor, delivery, and early postpartum as a time when the unexpected can happen. You have massive hormonal changes, you know, whether that affects it or not, but you have major changes in pharmacokinetics and probably most importantly, sleep deprivation and stress. So I kind of go through the same safety measures, even if someone's been well controlled. So during that time, no driving. Talk to the mother about water safety for both the baby and herself. So I ask, even when the baby starts, they put it in the tub in the sink to still have another adult by it in case they have any lapse of awareness that the baby can't slip underneath the water. Ask her not to take any tub baths herself unless another adult is in the house with the door unlocked and they know she's in the tub, which a lot of women tend to take tub baths to help with the perineal healing after delivery. If they're like at higher risk for seizures, and I kind of go into the next level of asking them to change the baby on the floor, especially once the baby starts rolling over, so they can't roll out of the changing table, as that's a little bit older. Potentially, if they have, you have to think about their semiology, right? It depends. So someone who has just myoclonic jerks, which we see this is all they have, and you still have to think about, you know, maybe using a stroller in the house instead of holding the baby when they're walking around, going up and down stairs. When they're sitting with a baby, kind of using, you know, a couch or arm rest to help support them. Reinforce that they shouldn't be co-sleeping with a baby anyway. The pediatrics, American Academy of Pediatrics recommends that, but we don't want a seizure occurring and suffocating the baby during the night. Before I move on, someone asked about why Keppra extended release. So I tend to go to the extended release on any medication that has increased clearance during pregnancy. So with the increased clearance, you're going to have a shorter half-life, if you will. You do have a shorter half-life, and so that with the extended release, it sort of helps compensate for that. So I use extended release, but dose it twice a day during pregnancy. So I do that with lamotrigine, extended release, levetiracetam. Don't do it so much with carbamazepine. Don't worry about it as much because the clearance doesn't change much for that medicine. So but for those two medications, that's what I do. Now sleep, what we've adopted in our clinic, it seems to work, but we really strongly recommend that everyone get at least 4 hours of uninterrupted sleep. And the reasoning is, you know, it's sort of, who knows, but the reasoning is that they go through, it gives them a chance to go through the different cycles of sleep, into slow wave sleep and REM. And then to try to make up the other, you know, 3 hours potentially throughout the day or with naps. So that usually means that the partner or family member will have to give 1 bottle during that 4 hours with the newborn. And that can be pumped breast milk or it can be formula. It seems like if they do adhere to that sleep, it really does reduce risk of seizures. Because as you saw in her story, she was up, you know, every 2 hours without a break. So she had the seizure 5 weeks after. So we talked about if she wanted to resume valproate, but only if she stops breastfeeding. We don't know, but you know, if they haven't been exposed to it during the pregnancy, we don't like to start a new medicine with the exception of levetiracetam. So she decided to switch to valproate temporarily, but then she had side effects. She went back to levetiracetam, and she called to report a new pregnancy. This time she was on levetiracetam monotherapy. We maintained her target concentration, and the second pregnancy and postpartum period went better. So, so this is the data summarizing. This is a great summary slide by Torborg and Thompson, using the three main pregnancy registries, which is EURAP, which is actually across 42 countries and several continents. It's not just European. The North American AED Pregnancy Registry, which is based here at MGH with Lou Holmes. And then the UK and Ireland Epilepsy and Pregnancy Registers, they keep a separate register as well as contribute to EURAP, but they don't mix the patients in these two registries. So you can just see by the symbols, the consistent level of rates of malformations. So 0% rates of malformations. The general population is 1.5 to 3%. So you have to keep that in mind. And I always put that in context for patients so they don't think that by taking the medication, they're going from 0 risk to this, what they see as high risk. And it helps them to sort of accept, as we know, as medical practitioners, no pregnancy is without risk, but we're just trying to get the risk as low and as similar to the general population as possible. So what you see is these consistent signals, and this is actually kind of new, that oxcarbazepine. We have enough numbers to tighten up these confidence intervals to say, actually, this is now in the lowest risk category for malformations. This just came out with the EURAP data over this past year. It actually is lower statistically within the EURAP registry than carbamazepine now. It's not a huge difference, but statistically it is a lower risk. And then the other thing that we know is a very high and consistently high risk of valproate across these registries. So kind of in the middle now, or topiramate. Carb used to be considered one of the favorable ones, but with the EURAP data, as I mentioned, is a little bit higher in EURAP and higher than oxcarb. So it's still somewhat favorable, but topiramate has some risk also of low birth weight. So that puts it in a higher risk category, as well as this malformation rate. Phenytoin, phenobarbital, and valproate being high. And what one thing to consider is all the medications that aren't even on the list, we can't even put them on the list yet. So the ones we don't know doesn't mean they're safe. It means we don't have the information yet. So any questions before going on to the next case? Okay, so Susan is a 26-year-old right-handed woman who presented to neurology clinic, and she described she had episodes of a flushing sensation, feeling like a hot flash, lightheaded. She could hear, but she couldn't talk back. And this was occurring over the past 3 to 6 months and would last about 1 minute. And she said no loss of awareness or dyscognitive features. But then actually what brought her to attention, she had one new episode where her eyes, she was sitting on the couch, her eyes rolled upward. This was witnessed by someone. She slouched on the couch and she was unresponsive for a few minutes. And then she had no recall of the event afterwards. So anyone want to chime in? What types of seizures do you think she's having? Seizure, or are they seizures, epilepsy seizures, and what types? What category? This is where I should probably do the polling. Okay, okay, so focal seizures, someone said. Yeah, autonomic. So focal seizures, temporal onset, possibly. And with the specific features of autonomic to aphasic, autonomic, yep. Temporal insular. Yeah, I agree with all of those that, you know, sort of definitely more indicating that in that focal. And then, you know, it's always hard without a witness right there to know this, the first type, if she does have any impaired awareness or not, but the second one she clearly did. So from focal temporal insular onset, although difficult to know if possible, PNES, correct. That's always, I mean, that is a possibility. She had a past medical history, repair of a PDA at age 11, no family history, no other risk factors. She had done some graduate work in a basic science lab, but didn't go on to complete her PhD. She has no history of alcohol, drugs, or provoking behaviors. Her brain MRI was abnormal, and that's the part I'll come back to. That's the only thing I'm just holding out on a little bit, because I talked to her about a probable diagnosis of epilepsy. Levetiracetam was started and titrated upwards, increased to 3,000 a day because she was still having the events, but she continued, and she also had depression with unprovoked crying. So with 1 year, just changed to lamotrigine. Her side effects improved, spells improved, and lamotrigine was eventually increased to 400 milligrams per day. Thought she was doing great, but she had a motor vehicle accident 6 months later. She recalls feeling the head rush and feeling she was braking, but then she ran into a tree and does not remember that part of it. So with that event, that clearly, again, had a focal impaired awareness. And just in general, I'm going to maybe skip over this a little bit because this was for other people too. You know, the question, is she medically refractory? She did fail 2 medications, 2 high doses, because the levetiracetam wasn't just the depression, but it's also the continued spells, continued events, if the other type are also focal seizures. And what would you do next? So we added, or I added topiramate at that point. Spells still didn't improve, still occurring 1 to 4 times per month. And she reported feeling tired after her events, and she could nap, which to me always means that it's probably focal impaired aware, not just focal aware seizures. And yes, so looking at Dr. Alnaki says 2 failed AEDs pre-surgical evaluation. Yes. So then her fiance, which didn't even know she had a fiance, comes and reports current semiology. He reports she stops speaking, looks confused, brings hands to her face, rubs her eyes toward end. So really sounding more like focal impaired aware seizures, duration 20 to 30 seconds, returns to baseline within a few minutes, but it has to retrace the conversation for her. So at this point, she's on lamotrigine 500 milligrams per day, topiramate 400 milligrams per day, and microgestin combined oral contraceptive pill, which is a combined estrogen and progesterone. She's reporting cognitive side effects, especially word finding, and also weight loss. So went through, indeed, talked about coming in for monitoring. I took that part out. We have her events captured on monitoring for beginning the phase 1 evaluation. But what else should be on the clinic visit checklist? What should have been there actually from the very beginning? But now that, you know, it is, okay, medication adherence, right? What else should we be discussing? Folic acid supplementation, very good. Yeah, folic acid, definitely want to have that really prescribed in any female of childbearing age, no matter what their plans. And the question, yes, is she pregnant? And it is interesting when we have also, her seizures didn't really change, but when we get a call, like someone's, their seizures pick up, the nurse now knows, like the first question, could you be pregnant? Because we do see that, like sometimes at the very beginning of pregnancy, whether it's due to pharmacokinetic changes or other. And then another input, very, very important, contraception, especially because she's on high dose topiramate, and might make the OCPs not work. Very good. You guys are too smart. So her social history, she recently moved from California to Boston, and I think her fiance followed her later. Was she wasn't driving or working. She was working as a lab tech, and her fiance is assistant professor at Northeastern University, and sure enough, getting married within 6 months and want to stop contraception soon after to start a family. So we do need to talk about contraception and the interactions. And if now that they say they want to start a family fairly soon, what would you do if she's not going to go to surgery right away, let's say? What would you do differently about her medications? Keep her on the, so going back, she's on lamotrigine and topiramate. So topiramate, oh, get off topiramate, add folic acid, good. Decrease topiramate and consider lev. She was on the lev in the beginning and had the, didn't really help her frequency, and she had quite a bit of depression, she, you know, which she normally doesn't have. So didn't feel like that was a good option. So all of you are on the right track. So prioritization, add in folic acid and prenatal vitamin. So I at least get them on 1 milligram of folic acid. The prenatal vitamin, get them on if they're planning a pregnancy or right after conception, but I don't keep it on the whole time because it's another pill to remember, and they often get constipated and then they stop taking both. Consider oxcarbazepine. A lot of people are recommending, and that is with the newer information that just came out with having lower malformations than carb, which we didn't have at that time, but I'll still kind of touch on that. Consider Brib instead of Lev. You know, maybe, certainly less psychiatric side effects. We don't have safety information during pregnancy. Is it similar enough to levetiracetam to think that it's as safe? You know, we just don't know. Obtain levels and keep on lowest dose of topiramate needed. So certainly she had, you know, didn't have great answers, and that's why so many ideas are coming up. So we discussed the lower efficacy of her contraception, and then we went into the known versus unknown risk by types of medications, amounts, and how important it was to characterize her disease before planned pregnancy is key. I kind of take a look at things, sort of like thinking of like in surgery, you know, where they, the checklist manifesto where you pause. I think this is a time like you do a checklist and you pause, like, do they need an updated MRI scan before pregnancy? They can get an MRI during pregnancy, but they don't like to, you know, they don't like to do it unless it's really emergency. Do they need an updated EEG? In this case, video EEG. And if we're going to do video EEG for looking at also phase 1, it's also an opportunity to do her medication transition. So this is a table of the interactions. So we have our strong inducers, and remember, it's not an old medicine versus new medicine story at all. Unfortunately, it can't be that simple. For instance, prampanil is a strong inducer. Even the weak inducers can be a problem a little bit at especially higher doses. Topiramate and oxcarb, actually we put over here strong inducer, but also like rufinamide, clobazam, eslicarbazepine. And then the non-inducers, for instance, valproate's over here, even though it's an old medicine. So it's kind of a hard, you know, list to keep in mind. But we do worry about lower efficacy of any of the hormonal contraceptives, including oral contraceptive pills, but also things like the vaginal ring and the patch, and even the Nexplanon, which is an implant of progesterone. And then moving on, I just wanted to show this one point that valproate we talked about, and I showed you the data for the higher rates of malformations, but equally important, or I don't know if you could say more important, but really a lot of the extra restrictions came out from the FDA and from the European Medical Agency because of the findings from our NEED study, where the IQ was lower in children exposed to valproate in utero compared to the other medications in this trial. So these women were on monotherapy with valproate, and they had lower IQ than the children born to women on phenytoin, on lamotrigine, and carbamazepine. And we do have a lot of data about the safety of carb on neurodevelopment. So that's why I still keep it in, somewhat of a favorable option. We also have, I'm not going to show a couple other things I'll just show, but the folate is interesting. So we think about taking folate to reduce the risk of major malformations, which is true in the general public. But in women with epilepsy, we don't see that protective effect on malformations, but of course they should be on it. But what we did see in NEED is if women were taking folic acid prior to conception, her children did better on their IQ testing later on at age 6. So within the group exposed to carbamazepine, if the mother was taking folate, the IQs were sitting up here, but if she wasn't taking folate, they're down here. And this was after corrections for many, many things, such as maternal IQ, socioeconomic status, et cetera. Same was true with lamotrigine, within phenytoin, and within valproate. So that's why we really also need to make sure our female patients are on folic acid. The other thing is there's 2 studies that show increased risk for autism for children, 2 valproate, and then a couple others that actually show anti-seizure medicines in general. And this study also showed that if the woman was taking folic acid prior to conception and continuing it, the adjusted odds ratio was better if she was taking folic acid for autistic traits in her children. So, so again, another reason for the folic acid, but also our concerns about valproate also include the neurodevelopmental effects and autism. Okay, so moving back to the patient. So she came in for monitoring, and we used that opportunity to transition her from lamotrigine and topiramate to lamotrigine and carb. And again, that's because the carbamazepine had better favorable data for malformations and especially for the neurodevelopment. We did get, the seizures were left frontotemporal, so a little bit more diffuse than certainly not a standard mesiotemporal lobe epilepsy pattern. And then we transitioned to her after her admission to carb monotherapy. So in general, we still prefer monotherapy if we can. And she continued to have very brief head rushes, 1 to 2 per week, but did not, wasn't having the impaired aware episodes and verified by her fiance. But it gets more interesting. So this is her brain MRI scan. So anyone want to say what you think the findings, pertinent findings are on her brain MRI scan? Hopefully that's coming over Zoom okay. Yep. PVH, periventricular nodular heterotopias. Yes. From Husam, from Adwat. I'm sorry, I'm not good with pronunciations. Yes, so her periventricular nodular heterotopias. So here you can see on the axial and on the coronal. So unfortunately, she's not a straightforward resection candidate. Of course, you can argue all kinds of things now, right? Between neuropace, between, thalamic stimulation, but, certainly not a cure. This started a whole other conversation that I think is going to become more and more common in our patients. for pregnancy with epilepsy is we're making a lot of headway. So at that point, this was a few years ago, actually, I sent her to someone doing research at Beth Israel to get her genetic testing, which now you can just get, but certainly she had an abnormality identified in the filamin A gene on the X chromosome. So this particular abnormality is responsible for about half the known cases of PVNH. And if the male baby inherits it, has a 50-50 chance of inheriting the mutation. If so, the baby's unlikely to develop, resulting in miscarriage. If the female baby has 50-50 chance of having it, and it would be a milder form that can vary quite a bit, such as this, woman who didn't have seizures till later, and she has, she's above average intelligence, to more devastating effects. So we talked to the couple about several options. One is proceeding with pregnancy naturally. One was pre-implantation genetic testing. So the woman goes through in vitro fertilization, and then the embryos are chosen that don't have the mutation, and then the ones that don't have the mutation are implanted. Another possibility is to go through pregnancy normally and doing early prenatal genetic testing, such as through chorionic villus sampling. Another option would be egg donation, or embryo donation, or adoption. So they decided they wanted to just go ahead and see what happened. So a BNS was placed to try to decrease her seizure burden and allow us to use lower dose medicine. She was diagnosed with polycystic ovarian syndrome. Vitamin D I always get prior to pregnancy and make sure it's replenished. And I think because I can't remember the decision why folic acid 4 milligrams per day, and again, we don't know the dose, obtain free and total carb levels, and then we tried to decrease her carb dose going into conception and repeated the levels during pregnancy. So she had a spontaneous pregnancy, but then we offered early prenatal genetic testing. They were considering it, and then fetal demise at 10 weeks gestational age. And they had an autopsy, and well, for what you can do, products of conception were tested, and it was a male who had the mutation. So after that, they decided to go ahead with pre-implantation genetic testing with IVF. Continued to optimize BNS settings, attempted to lower the carb dose some, but the goal, remember, is to prevent the convulsive seizures, which are particularly higher risk during pregnancy to both the mother and the fetus. And we want to avoid significant worsening of their focal seizures. But you're not going to take someone who's medically refractory, drug resistant, and make them seizure controlled. So try not to get into this cycle of they're still having seizures, I have to keep changing the dose. You want to just make sure they try to stay stable for the patient and for her safety. So we decreased her dose some, and so she had IVF with PGD, had a healthy baby girl, and then she just delivered her second baby girl a couple weeks ago through, again, IVF with prenatal genetic determination. So I have another family. I have a woman right now with really interesting family history, just crazy. She has juvenile absence epilepsy that's well controlled. One of her children unfortunately developed Dravet, or met criteria for Dravet, and has the SCN1A mutation. Then her second child just started developing absence seizures at the age of 5. So she's being seen by the genetics group at Children's. She, whether she has SCN1A, they're going to test her now, and then she'll be undergoing also this prenatal genetic determination if she has the abnormality. So I think we're going to see this more and more. So let me try to just get to a few points. I'm going to just actually try to get through a few points because it's getting late. So let me just highlight some points. So this is a woman, a 25-year-old, who had a sagittal venous thrombosis at the age of 25 in the setting of estrogen-containing oral contraceptive pills. She then developed seizures, which progressed to a bilateral convulsive seizure initially, but then afterwards, and she was treated, she would still have her semiology was her right hand would twitch, and she'd get dystonia of her right hand, and afterwards she'd get a little bit of a postictal Todd's paralysis, but it wouldn't progress to impaired aware seizures, which makes sense, right, because of her localization. And she had one additional convulsive seizure in the setting of medication non-adherence, and it was preceded by an escalation of these focal aware seizures. She had been on levetiracetam, transitioned to lamotrigine, and when I met her, she was on lamotrigine 800 milligrams per day with 2 simple partial seizures every 3 months. That's pretty high dose, but her seizure frequency is pretty low. So the point is, going back to this publication in 2018, but it first came out, I think, in 2011, and this really made an impact on how we prescribe. Going into pregnancy, the malformation rate goes up with higher doses at conception, even for our, quote, safe medication. So lamotrigine, if the dose is over 325 per day, the malformation rate is significantly higher than if the dose is less than 325 milligrams per day. For all the medicines they had enough power to look at this. It held true for carbamazepine, for phenobarbital, and this is what we were talking about, the valproic acid. Look at this, over 1450 milligrams per day, 25% malformation rate. So I discussed with her, what is the benefit of being on 600 milligrams per day? And really, does going into pregnancy, should you be that high? So you have to consider what are their seizure types and also emotionally how they are. We all have some patients who it makes them so anxious to have any risk of increased seizure frequency, and others, like she's like, yeah, so we brought down her lamotrigine dose. Her focal aware seizures did increase in frequency some, but not really that different than not a lot different than prior. And she, we were trying to make sure she didn't go into generalization, so had rescue lorazepam at home if she did start having an escalation, and we kept her target concentration of 4 to 8, and she did very well. So I want to just make a few other points about, so lamotrigine, as you know, increases clearance during pregnancy, but this is from a more formal modeling study. This is at 0 weeks conception, and this is at delivery 40 weeks. And we see 2 populations. The majority of women are in this population where their clearance increases 220% above baseline. So essentially their clearance is about 3-fold what they started at. So if you have someone going into pregnancy at 300 milligrams per day with use of therapeutic drug monitoring and deciding whether you need to keep their level, it will not be unusual to have the dose at delivery of 900 milligrams per day, for example. Unfortunately, there's enough variability between patients that we don't have an algorithm. We're working on it, but so you have to check monthly levels. You might also have, this is about 20% of the population, 20% of the population who has this lower clearance where their clearance only goes up by 20% during pregnancy. So if you were to just do an algorithm, you're going to get these people lamotrigine toxic and overexpose the fetus. So what we do then after delivery, let me go back a second, sorry. So this is pretty scrunched, but if you take this out, they return to baseline clearance over approximately 20 days. So what we do after delivery, we reduce their lamotrigine back to their pre-conception dose over about roughly about 2 weeks, 2 to 3 weeks. And there was a prior study we did before we knew that, and when we decreased lamotrigine over 10 days empirically, we saw that people didn't have seizure worsening and they didn't get toxic. If you don't make the changes, they're going to get toxic. They're going to have double vision. They're going to be unstable. They're going to fall with the baby. So you really need to you can't get levels. There's not time to get levels. So you just decrease it over that time. And usually what we do is decrease to a little bit higher than their pre-pregnancy dose because of all the sleep deprivation. So maybe like 50 milligrams more. Now, similar principles are applied for oxcarbazepine, which also undergoes glucuronidation. And renal excretion returns to baseline over 2 to 3 weeks. So we bring the dose back down of levetiracetam over that same time, or lacosamide or zonisamide. And then this P450 metabolism, unfortunately, they're quite different between the different, there's a lot of different enzymes. So carb doesn't change a lot, but phenytoin does. So, and it changes back to baseline more slowly over a couple of months, but this part has not been worked out very well in studies. We talked about breastfeeding, and so just to reassure, there's studies that the NEED study, we looked at IQ in the children who were developing and were breastfed, had no ill effects of the breastfeeding, although the medication is in the breast milk. And we recently published this paper where we looked at the infant concentrations compared to moms. And so lamotrigine was around 30% of moms, so it's a lot lower than what the baby sees during in utero. So we encourage the breastfeeding. And also, just to let you know, levetiracetam was very low. In fact, a lot of it wasn't even detectable. Here's carb, ox carb, and here's zonisamide, a little bit higher, but we only had four subjects on that, so harder to make much out of that. So that can be reassuring. So kind of in summary, when we look at teratogenic risks, we have a lot of information about lamotrigine and levetiracetam having low malformation rates and also good neurodevelopment. I didn't show it, but levetiracetam, there's a few studies from the UK and that show that the neurodevelopment looks good. We're doing a much more detailed study right now called MONEED, where we'll get more information about that. Carbamazepine is a little bit higher risk for malformations, but we know the neurodevelopment is good. Oxcarb and zonisamide, their malformation rates are low, but we don't know neurodevelopment yet, so I put it in this category. And then we know concerns about higher malformation rates with these medications, higher risk for neurodevelopment with phenobarb. Valproic acid has the highest. And then someone asked about, so lacosamide, we don't know. I can't say we are seeing it in pregnancy a lot. So I don't think it's going to be, I don't think it's going to be about Pro8. I can't say that for sure, but we're not seeing signals of concern yet. We do have quite a few of the patients in our MONEED study, so we'll get some neurodevelopmental data from there. The problem is that it's not used as much in other parts of the world, so we're not getting the information for Europe, and we're just starting to get reasonable numbers in the North American AED pregnancy registry for the malformation rates of lacosamide. So I hope we'll have that information soon. And then, yeah, I thought someone said, also just another medication we're seeing just used a lot in clobazam, just to let you know that I have real concerns with that. The clobazam, there's small case series app, the rates of malformations were very high. Of course, it's always in polytherapy, so it's hard to sort that out. And then just by its mechanism of action being the GABA benzo receptor complex that has, theoretically higher neurodevelopmental risk, and also such as fetal alcohol syndrome. So we do have concerns about clobazam, which, unfortunately, we've seen quite a few people coming on clobazam after they're pregnant and kind of trying to manage that. So kind of just to go over transition to medication with favorable teratogenic profile, especially if someone's planning a pregnancy, but remember 50% of pregnancies are unplanned. So I have the conversations early, always have them on folic acid, establish the individual target concentration. Think about if you can lower your dose, such as the woman who had focal aware seizures. During pregnancy, we do get monthly AED levels to maintain therapeutic drug monitoring. So someone, I might say their lamotrigine range is 2.5 to 5, someone else it might be 8 to 10. So it depends upon their history, their seizure types, how resistant they are, and hopefully you have a preconception level to help with that. And then adjust doses during pregnancy for seizure side effects, and to maintain your concentration at least 65% of what your target concentration is. Team approach with OB, and afterwards adjust dose, talk about breastfeeding plans, and also newborn care. So with that, trying to, so we have still a little bit of time, even though it's getting close to hopefully meal hours for some of you or back on call. So what other questions or comments do people have? And again, feel free to use the mic, especially. So contraception, it's a good question. I would, I encourage our patients to consider long-acting reversible contraception, which essentially are the IUDs. But a lot of people just don't want that. But out of the IUDs, Mirena IUD and Skyla have some progestin that goes into the endometrial cavity, and it decreases the buildup. And so those are actually probably the better ones to use. Sometimes it's very confusing. People are like, well, there's a hormone, and the hormone's going to make my seizures worse. First of all, it barely gets into the bloodstream, and it's a progestin, it's not an estrogen. And there's a nice study recently published by Ann Davis and Allison Pack. They did I think it was called WeSail, where they actually did a study of the tolerability of the IUDs in women with epilepsy. But the bottom line is actually that birth control pills are by far the most common form of reversible contraception in the US and still favored. So, certainly we just talk about adherence to those and also consider the interactions, of course. So if they're on a strong inducer, then I really encourage them to consider other options. And I have a great gynecology group that specializes in medical contraception. And so it helps to work with them on these patients. Sometimes if they're hormonally sensitive, we will put them on a continuous oral contraceptive pill to reduce the cycling of the natural hormones, and it can help the seizures. It's not been shown in any trials, but it is a strategy we often do, and sometimes it seems to work. But it's nothing that is, a huge advantage, but it can help. Other questions? Comments? No. Okay, well, thank you for your time, especially I know how busy you guys are, and I hope you got something out of it. And everyone, I don't know what your duties are. I know they're pretty crazy at a lot of places, covering COVID ICUs and, adjusting to not having our normal epilepsy volume. So I hope everyone stays safe. I do have one more question. So do I adjust my dose of folic acid based on AED? So you probably saw, I think it was the carbamazepine story. I don't know. We just had an international panel and we put out a paper. And this was, I swear, this discussion took more time than anything else. And basically, what are the practice preferences, and that there's just absolutely no literature out there to guide us. So people tend to use 1 to 4 milligrams per day. I tend to do 1 milligram per day. I write a prescription. I just find adherence is better if they have that prescription they pick up with their seizure medicine than getting it over the counter. And over the counter, you can only get 0.4 milligrams. And then if they're on, like, I don't know, CARB still has a little higher rates of neural tube defects, so I'll sometimes bump it to 2 or 4 milligrams, or if they are on valproate, which is, very unusual to be on it, but there's nothing, we just don't know. There's still some places like Canadian OBGYN Society that recommend 5 milligrams per day for all women on AEDs. But there was a recent report in the general public that if folic acid is too high, like 5 milligrams per day, it increases the risk for autism. So people started, worrying about that. It's really a poorly designed study to know if that's true, but it's kind of made me feel like 1 milligram per day is a good compromise, but no answers on that. So with that, I'll sign off. And again, thank you. And you guys have a good week. Thank you.